It's not going to go anywhere, but it absolutely can be better managed. The innovation that gets me excited about this grant opportunity with Dr. Carter and his team, and this process for collaboration, it gets me excited because innovation is the key. Coming here to the county in this role was pretty awesome, but I didn't know what I was getting into. My background is Kaiser Permanente and integrated healthcare for all of my life. I'm a military brat, so I only know integrated healthcare. And so I was stunned coming into public health, understanding that it's full of silos. So I am very, very excited that this grant was awarded. And it sounds like it was a hard battle and sought and won. I'm proud of this team. But I'm more proud of the work that you guys will be doing around innovation and how we can combat some of the basic things that impact the majority of populations for all of the counties involved, particularly here, Prince George's County. When you look at the demographics, it's a heavy burden. In my 30 plus years in healthcare, I'm seeing a wonderful face. You can have that seat because I'm going to miss Dr. Thomas. That's my honey. I'm going to see your face in a minute. 35 plus years in healthcare. These have been problems. I know them well, and running away from DNA and historical things is very hard to do, but it's not impossible. So I am tickled that this grant will give us an opportunity to leverage some of that. 12 million over 5 years is not chopped liver. So it's good when you can get funding to do the kinds of work that we really believe can make a difference. So thank you, and have fun. I hope Doc Carter is serious about getting you on the road before 3. It is a Monday and a Thanksgiving holiday week. And just the fact that the room is full tells me that you all are excited and serious about making a difference in these communities. So thank you very much. My main job as health officer is hassle factor remover. So if hopefully there are no hassles that I have to get in, you've got a serious team working here, and I encourage you to run and run fast. Thank you so much. Dr. Carter. We're going to start with introductions, which I always miss, so I'm going to make sure I get that done. We're going to go around the room. What I would love for you guys to do is just say who you are, and your organization. And that would be great. So we'll start with you, Brenda.
Good morning, everyone. I'm Brenda Lee, and I'm pleased and very much delighted to serve as the project director for this wonderful initiative. So I look forward to getting to know each and every one of you and working closely with you.
Thank you.
Good morning, I'm Maureen Thomas, grant writer, and also the evaluator, part of the evaluator.
I'm Dr. Collins, Sir Collins Lemonson. I'm Jasmine Winters, I'm assistant to Dr. Collins.
Good afternoon, I'm Greg Taylor from the Environment Health and Wellness Foundation.
Cynthia Bauer, director of the Horowitz Center for Health Literacy at the University of Maryland.
I'm Anna Shaw, I'm the project coordinator at the Horowitz Center for Health Literacy.
I am Christy Peer, I'm the director for the Center for Chronic Disease Prevention and Control at the State Health.
I'm Trina Frazier, Prince George's County Health Department, Health and Wellness Chronic Disease Program. Anita Mulu, president of the Health Improvement Research Corporation.
Divine Changek, CEO, Community Application Research Corporation.
Good afternoon, I'm Brandon Nicewinder. I'm Chief Operating Officer at CRISP.
Hello, Sylvester Tuchali, Health Planning Development Administrator for Health.
Good afternoon, everyone. I'm Jacqueline Val Harvey, the other Deputy Health Officer, and I have oversight of behavioral health, fiscal administration, and environmental.
Hi, I'm Delia Williams. I'm with the Prince George's County Health Department. I oversee the communications office.
Hello, my name is Darlene Saunders. I work
Special Projects Manager with the Prince George's County Health Department, Health and Wellness.
Good morning. Oh, good. Good morning. I'm Jean Drummond. Sorry, I was over there. I apologize. Jean Drummond with Healthcare Dynamics International.
Good afternoon, I'm Juan Monroe with the Institute for Public Health Innovation. Program coordinator.
Christine Stewart, this is program manager for the Institute for Public Health Innovation.
Magali Rodriguez Cepeda, Associate Dean at the University of School of Pharmacy.
I'm Virginia Brett, Central Health Quality Indicators.
I'm Karen Chandler, and I'm also with Health Quality Editors.
Hi, everybody, I'm Linda Aldori, and I'm at the University of Maryland in Health Communication. Hi, I'm Sue Cullen, and I'm with the Prince George's County Health Department, Chronic Disease Coordinator.
Hello, I'm David Chernow, the Executive Director for TLC MD.
Hi, everybody. I'm Lori Werrell, Director of Population and Community Health at MedStar St. Mary's Hospital. And I now can put a lot of faces to names.
I know.
Right here.
I feel it.
And I'll be serving as a liaison with the Health Community.
I'm Laura Wilson, Executive Director for the Maryland Rural Health Association.
Barbara?
Hi, I'm Barbara Banks Wiggins, Executive Director of the Prince George's Healthcare Alliance. Hello, everybody. Good afternoon. I'm Wanda Smith, Social Worker with Prince George's County Healthcare Alliance.
I'm Molly Gargis. I'm a nurse practitioner and also a Master's in Public Health intern with University of Maryland, working with Jay Chernoff and Joseph.
Yes.
Hi, everyone. I'm Caitlin Murphy. You've probably seen emails from me. So I'm acting as the project coordinator, and I'm really happy to have you all here today. Thank you for making the long journey for those of you who came up from the southern counties. We're excited to have you here today.
Suzelle?
So Ben Warren, I'm the fiscal officer for administration of the health department. Nice to meet you.
Michael? I hate to catch you when you're walking, but Michael?
Serves me right for being a few minutes late. Good afternoon, I'm Michael Ryan with IHI.
I think we got everybody. So you see, we have a large team of people. And there's a lot, and this is exciting work for us. This is a passion of mine. And so I really want to sort of convey that to you guys and so that you understand how we're going to go about getting this done in this 5-year period. You all already know the background to diabetes, chronic hypertension, and stroke. I'm just overcome actually by some of the numbers, especially as a physician, when you look at what's going to happen in 2020, and it's going to be almost a 32% increase in diabetics probably in the United States. And the other thing that frightens me is that, as you all know, this epidemic of diabetes and heart disease and stroke is growing. And we got to put a brake on this. We really do have to try to come up with innovative ways to break this. So I put these slides in as just a reminder that we've got serious work to do. And the most important thing is that everything we can do is preventable. Everything that we can do to stop the disease can be done. And the studies have proved that. So that's what really overwhelms me, because it was back in 2001 when the New England Journal of Medicine published that study that showed that lifestyle interventions can reduce the incidence of diabetes and over metformin, which is the medicine of choice. So once that hits your brain, then you realize that we've got significant work to do. We can do that work and show the cost effectiveness of that work, and the programs that people have already started can be expanded. And that's the goal here. The goal here is to bring together the partners to expand the work that's already been done, use innovative interventions to make sure that we can expand that work and increase adoptability, to come up with even more innovative work to help with, on the health system side, doctors make better decisions, help with medication therapy management, help with providers who can work at the top of their license for non-physicians to help us get this done. This is community work This is village work. This is not individual work. So this is not one hospital. This is not one program that's working for lifestyle change. This is not one entity. This is a collective effort. And the reason I really was excited about this program because we could do it for Southern Maryland. Because we have a continuum, as you all well know. We have urban all the way down to rural. And that continuum is something that has to be addressed. It hasn't been addressed in the, I think, in the way that we can do it. I'll say that. And we've got enough brain trust and enough innovators and people to be able to do that. So and for this program, what we did was, what we proposed, that we come together as 4 counties to address these issues, and then to build a network of primary care, health systems, hospital system folks, and public health people. Bring that together into one large network that focuses on not only these diseases, but also our high utilizers, because our high utilizers are people with these diseases, especially the older people who have at least 4 chronic diseases or more. I mean, it's expanding. So we've got a larger vision than just the specific diseases. We want to set the infrastructure tone for the Southern Maryland region so that we can help all those patients and make a dramatic change. Now, this is sort of an extension of what we were doing with the Health Enterprise Zone, and I have Lori right here, who is my
PTSD over this.
Which we did have PTSD. But this is really an extension of that, because that's what we were trying to address in the Health Enterprise Zone. Whether I was here in Prince George's County, slaving away trying to figure out how to do it in a more urban setting that was in 20743, which is Capitol Heights, and Lori was down St. Mary's, slaving away trying to figure out how to do it in rural counties. But when we came together, we found that we had more things in common than we had differences, and that we were learning from each other, and we were just at the precipice of going to the next step, and then the funding stopped. So now we said, now we want to put some infrastructure in place. We're going to make sure this is sustainable. We're going to make sure this is sustainable. We're going to grow the programs that are already here. And we're going to use all of the resources that we have. CHRIS, which is for our information systems, the hospital systems, the public health systems, everything we have. We're going to do that. And we have a really wonderful partner in HQI, who's the QIO, the Quality Improvement Organization, who stepped up to the plate and said, yes, we will do this. We have TLC, which brought a lot of hospital systems together. It allows us to move forward. We have IPHI, which is, their whole mission is to help health departments do this type of work. We have our SANS back in the back, who also works with physicians in physician transformation. We have the Maryland Rural Association, who is our partner in crime and making sure that we get our boots on the ground to do those types of things. We have our University of Maryland partners who have been partnering with us for a long time in communications and in health literacy. We have Dr. DeBidner, who we're constantly trying to make sure we get to that next step, who does medication therapy management and help our people who are working at the top of their licenses and make sure that we have a total integrated care coordination. And we have our care coordinating entities, like who work with like the Alliance and Health Access. And then we have the DPPs themselves, who we have, and we have the health departments. So we got a lot of folks here who can do some really good work. And on top of all of that, the infrastructure has already been laid by the state. The state has laid out a lot of great things that we have to understand how we can leverage and expand. So you see, I'm excited because this is exciting stuff. This is where we should be. This is exactly where we should be. So, this is the region that we're talking about. This is about 1.2 million people, and 12% of it is rural. But the other part that's semi-rural is just as rural as what they're characterizing as rural. So we have a lot of work to do. So this goes from urban to rural, and we're on that continuum. The statistics you all should know, so I'm not going to belabor them. You can look at them in your in the handout. What I wanted to go through right now is to give you some kind of idea of what we're projecting our outcomes to be.
And so, as you well know, that for this particular grant, there were two categories. Category A, which concentrated on diabetes, category B, which concentrated more on hypertension and stroke. And it's 8 strategies for category A, 8 strategies for category B. So for category A, our long term, that means at the end of 5 years, and this is ambitious, I'm not saying it's not, but we believe that we can do this because of the people I have in the room. We expect to have a 25% increase over the baseline, a number of people with pre-diabetes enrolled in a CDC recognized lifestyle change program to have achieved a 5 to 7% weight loss. Now that's not unachievable. That's something we should be able to do. Number 2, we want a 25% decrease in the number of patients with diabetes who have A1Cs greater than 9. That's achievable. We should be able to do that, especially with lifestyle change. We also, in addition, we want our long-term outcomes category A activities to reduce hospital readmission. And we can talk about that. We can talk about the significance of that, but that's one of the goals we have as our enterprise zone. And we want to see a decrease of at least of utilization at least by 10% per year. So that's category A. Category B, our long-term outcomes, what we want to see is a 50% increase in the number of patients with known high blood pressure who achieve blood pressure control. That is extremely ambitious. I'm not saying it's not. But you gotta have a goal. I believe we can do this. Number 2, if we want a 50% increase in the number of patients at risk for cardiovascular events whose cholesterol is controlled. We should be able to do that. That means that we have to work very closely with our health system, but we should be able to achieve that. We also propose the following service utilization, and again, we want to decrease the number of people, high utilizers, who overutilize the hospital system at least by 10% a year. Those are our outcome goals at 5 years. If we achieve that, I'll be happy as a clam. You all should be happy as a clam. I hope CDC is happy as a clam. Anyway, I sort of named the partners when I was going through my initial talk. These are the partners that we have. We're extremely happy about our partnerships, and I believe that we've got the right combination of folks to do the job. So I'm going to briefly go over the strategies in category A and B. You all already know them. I hope you know them if you've been able to see the proposal, but I'm going to go over real quickly. Category A is mainly about implementing systems to facilitate bidirectional e-referral between the lifestyle program and the health system, bidirectional. But not just the health system, as I see it. This e-referral program should be referral from all sources that makes sense, that should be referred into the program, and that needs to be referred to the health system. The second one is to support organizations in increasing enrollment. We have some of the organizations here. Our goal is to increase the enrollments of the organizations that already exist. So that's really important. Not only that, is we need new ones, we create new ones. And we're going to be proposing doing some virtual practice. So we'll talk about that. A3 is to implement tailored communication messaging to reach underserved populations. Well, that's important because if we're going to get to increasing enrollment, we've got to be able to reach people where they are and make sure they understand the significance of the program that we're doing. We've got to support advanced training for lifestyle coaches. Well, that makes sense. But what we need to do, so it fits right into how this strategy would work. Number 5, we want to eliminate the barriers for participation and retention into the CDC recognized lifestyle change program. Well, that makes sense. That's true for.
Yeah, stay by the mic. Okay.
That's true for. Sorry. That's going to not only be true for diabetes. That's going to be true for any program that could cause a significant change in a chronic disease. So putting in finding out and eliminating barriers to participation is incredibly important. And that's why I ask people who are experts at this to do that type of work. Number 6 is to establish or expand the use of telehealth technology. And we're definitely going to do that. It's around not only diabetes management, but also with the ADA recognized and the AADE accredited DSMES programs. And don't ask me to say that again. But we're going to do that because we had been working toward that in our health department, putting these types of programs online, and I think this is going to be an extension of that. The seventh one of the A category is to increase the adoption and use of clinical systems and care practices. And that is our partner. We have partners who are working with providers who can help us get that done. And the last one is to increase the use of clinical support within the EHR to promote detection of chronic kidney disease. And we got partners who can help us do that too. So in the B category, there are 8 ones there too. These are these are strategies. Number 1 is to identify patients with undiagnosed hypertension using EHR and HIT. The second one is to determine ways to promote the adoption of evidence-based quality measures at the provider level. And this is exquisitely important because this isn't being done. And with that adoption and the e-referrals and the expansion that we talked about, not only for hypertension, and not only for hypertension, but for diabetes and whatever, this is going to make a big, big change. Why there's a barrier there is not 100% clear to me, but we're going to overcome that barrier. The third one is to engage non-physician teams in innovative ways to help us with this adopting this better management. And I'm really confident that we can do that. We have experts who understand how to engage non-physician teams. The fourth one is to the promotion of the adoption of medication therapy management. And Dr. DeBidner and I guess she is the champion of this. I don't have any doubt. We've been trying to get this done because we know this works. We know this works. This is one of the pillars of care coordination. If you can't do this, you're not going to succeed. In any of this, diabetes, hypertension, stroke, you've got to do medication therapy management, and that's so important. And we know, so I was excited to see that was included in the strategy. The fifth strategy is to facilitate engagement of community health workers and patient navigators, and that's the kind of work Lori and I have been in when we were in the health enterprise zone. We know that works. We know we can extend that to hypertension and cholesterol management. Number 6 is to implement systems to facilitate bidirectional referrals like we did in A1. So we're going to make sure that happens the same way that same way we have to facilitate the bidirectional referrals. The 7th one is to expand the use of telemedicine, telehealth. We can do that. And lastly is to enhance referral participation and adherence in cardiac rehabilitation programs. And with the systems that we're setting up and the network we're setting up, we should be able to accomplish that. So with that is the overview. I hope you all got a sense of where we're going with this. But now I'm going to hand it over to Dr. Thomas to give an evaluation for it.
Good morning again. Unfortunately, I have a meeting to go to, so that's why the evaluation is going first, and I apologize for that. Afterwards, you will get more of a project overview. But I should be able to advance the slide. Just hit enter. Okay. So for this initiative, there is a team of evaluators. I'm the lead process evaluator, and outcomes evaluation primarily will be handled by University of Maryland, Baltimore. Those 3 persons mentioned there. Unfortunately, none of them are here with us today, so I'm going to do my best to talk for me and for them. CDC has given us an evaluation framework. There's the CDC-led, which is actually a national contractor that they have retained that will evaluate all of, I think it's 26 of these programs and funded. And then there's the recipient-led, which is our responsibility, and their performance measures which there will be a uniform set across all projects, and then we're able to add some that we find particularly interesting. And we're in the process of thinking through that. So the evaluation, well, CDC has given us an evaluation, well, 2 evaluation officers, and we are going to have evaluation TA. So there are a lot of details that are still to be worked out. And since this is a cooperative agreement, we are not at liberty to run ahead. We have to work in collaboration with CDC and, of course, with you, our partners. But these are the 3, these are the different components and what each of them aims to do. CDC is really interested in finding out new learning and new ways of promoting care coordination and improving chronic disease management. So there's a lot of interest in documenting lessons learned, best practices, and things of that nature, and informing future funding opportunities. So I'm not going to talk about the national evaluation because we don't really have too much detail on that. I will go to the recipient lab. And interestingly, when I was writing the grant, I assumed that, you know, we needed to write a full-scale process and outcome evaluation. And then when we had our first evaluation meeting with CDC, they basically said that their real interest is on what they're calling rigorous evaluation of 4 strategies. 2 under category A and 2 under category B. And we'd already proposed, and that's a later slide, what we will be working on. Those are the real outcomes that they're looking at, in addition to the performance measures. So it kind of narrows the scope in a way for the outcome evaluation. However, we, as the health department, we're still going ahead with the process evaluation for 2 reasons. First of all, just for basic accountability, and then because, as Dr. Carter pointed out, this is not a standalone initiative. This is part of a very deliberate strategic plan, and we need certain data and certain information to inform future grants, and also to think about and improve the way that we work with all of you, our partners. So there will be a full-scale process evaluation that will get at some of the information we need to improve our partnerships, to strengthen, for instance, the nonprofit and public interaction that's going to make this a success. So the rigorous evaluation, this falls under the University of Maryland, Baltimore, and these are the requirements the CDC has set. If you look particularly at the second bullet, experimental design, quasi-experimental design, and so forth, this will require them to work very closely with the strategies, with whoever is implementing the strategies. Because if you can imagine, if we're, for instance, doing an experimental design, that's going to affect how you recruit people, patients into the program and how they're served. So you can fully expect that, depending on what strategy you're going to be working with, that the evaluators will be contacting you very shortly to figure out how we are going to work together in a way that makes sense. My background is in community-based evaluation, participatory methods. So I personally am an advocate for not having onerous evaluations that, you know, drive providers and patients crazy, but we still have to adhere to this. So there's going to be a lot of dialogue and back and forth to make sure that we can meet these requirements and at the same time allow you to do the work in a way that makes sense. So here are the 4 strategies, and I don't know yet, and I'm sorry I wouldn't be here for that part of the presentation to find out if work is already, if the health department's already decided who's going to do what on this. I know when we were writing the grant, we asked for input, and so I had a sort of basic idea of who might be doing what, but as I said, probably the next couple of weeks, you should be expecting to hear from the University of Maryland and seeing how you can work together on those. The performance measures, CDC, as I said, is going to have a uniform set of measures that all 26 projects will have to collect, and they told us, I think it was last week, that they will be sending out their initial ideas in, I think it's early December. We're supposed to comment on those, and then we're supposed to also provide any that we specifically want to have for our project. So here are our deliverables. Typical with grants or cooperative agreements, kind of got a late start, but they're holding us to this April 1st, 2019 date, where we have to have a full evaluation and performance measurement plan in that we need to submit to CDC. And the recommendation is that we might want to send them drafts ahead of time so that when we do submit on April 1st, we have a pretty good chance of it being approved without any problems. And then the rest is basically standard annual periodic reports. So in the evaluation plan that we need to prepare, that's our main focus right now, is meeting this April 1st deadline and having a solid plan. And so these are some of the things that we have to address. I think a big concern for us is getting good baselines, and also, well, before we do that, identifying data sources, and then getting really solid baselines. So, again, this is from the outcome side and from the performance measurement side, and University of Maryland will be reaching out to you to start this dialogue so we can figure out what we need to do. My recommendation, and I think Dr. Carter will agree with me on this, is we want to get the information we need to really answer questions, the key evaluation questions, but at the same time, we are not trying to collect tons of data. I think it's really important. There's so many moving pieces here, we could get lost in the data. So we really want to be very clear and very succinct about what it is that we're trying to answer. And so hopefully by having this process of dialogue, we can, reach consensus. The process evaluation questions, going to be looking at developing implementation reports. Program learning, which is very exciting because it involves a community of practice that's going to be set up. And I'll talk a little bit more about that in another slide. Participant satisfaction is very important for us, not only to look at whether patients are benefiting from this initiative, but how we are doing as a collaborative, working together. Our providers and the partners, how satisfied are they with how the work is going. And so these three areas are my responsibility, and again, I'll be reaching out to you to talk about ways in which we can measure this in a way that's not onerous, but still gives us the information we need. So, even though CDC, when we talk with them, really stress the rigorous evaluation, they then also put in the importance of bringing to the fore lessons learned, best practices, and that type of information. So we had already proposed in the proposal how we were going to do this. If you have, I'm not going to take the time to go through all the steps, but if you're interested, you can read the evaluation section, document exactly how we're going to go through the program learning. So the key for that is really to get the community of practice up and running, and I'm looking at Brenda and I'm looking at Michael, and I know that will happen. Patient satisfaction, probably going to use existing measures. I would need to confirm with CDC if they're okay with us just taking selected questions from validated measures. Typically evaluators, the purists will say, that's terrible, you shouldn't do that. You need to use the whole measure. But again, I'm thinking, we've worked with this population before on the HEZ. This is a 5-year initiative. So if you keep coming back to people, let's say twice a year, and asking them batteries of questions, you're going to get a lot of respondent fatigue. So we have to take that into consideration. I'm looking forward to working with Linda Alduri and her team that have done a lot of work on the ground, grassroots, with HEZ, and can give us some ideas of how best to engage this population. Let's see what else. You have an advisory council not too sure who they are. Did we put that in the proposal? I mean, I know we put it in the proposal. Did we say who they were? No. No, okay. Yeah. Yes, well, we'll be checking in with them and looking forward to getting their guidance in some of these issues. Here are the outcome evaluation questions that we are particularly looking at, and they relate to the rigorous evaluations that we're proposing. And of course, because we have to participate in the national evaluation, we fully expect that CDC may require us to get other data that don't necessarily respond to these questions, but for their own interest and for the national evaluation. And here are the data sources that we highlighted in the proposal, and we think this is still valid, but again, we will, as we set up meetings and start talking to you, we will discuss what makes sense. And particularly, not only where the data reside, but how we're going to get access to it and who's going to collect it. It is clear that the University of Maryland will be analyzing a lot of it, but for instance, with clinical provider data, we know that we're fortunate to have the QIO on board, and they have a lot of experience working with providers, and we also have HCDI SAN on board, and they too work with providers, so we will be interested to engage you and your thoughts on how best to do this. So far, we had the CDC webinar, which set out CDC's preliminary ideas on how the evaluation should be conducted, and that was in October. And then we had an internal call that was held in November to kind of set the stage. And in fact, we haven't actually personally met. At least I have not met the University of Maryland people. We met on the phone, and we should probably be meeting in person soon. And so here are the next steps. This is what CDC is going to do. They said they're going to send us these performance measurement definitions for us to comment on, and they're going to send out various types of guidance, and they're going to have technical assistance webinars. So we fully expect to participate in all of that. For us, top of the agenda, but we can't do that today, is setting a schedule of regular evaluation working meetings. As you can imagine, we've got, 16 strategies or 14? 16. So a lot of meetings, but the University of Maryland and we will need to work with you and figure out a way to meet with you regularly to move the evaluation agenda. We also have to complete a capacitor inventory. If you've worked with CDC before, they have a lot of documentation that they will require us to complete. This does not necessarily involve most of the partners. One or two of them we might have to talk to about the inventory, but this is something we need to do. We also need to design the rigorous evaluations, and as I said before, that will require us to meet with the key task leaders for the 4 strategies we've selected so that we can figure out how we want to do this. We have to provide feedback to CDC on the performance measures, and I would assume that we would send those out to you, our partners, and as well as take a look at them ourselves and collate all of that feedback and send it to CDC. We have to specify potential measures that are in addition to what CDC has proposed. We need to work on data use agreements, and I think we've started working on that already, right? Yeah, good. Identifying and modifying participation and provider tools. We've done a little bit on this, and we're continuing to work on those. And then we have to draft our plan. And also, we need to prepare an IRB submission. And that will be going through the University of Maryland's IRB. So, as you can see, we have a lot to do. But that is it. I will be here until 2, but I think that there's going to be, you're going to hand out the contact information. So anyone that has any questions that can't speak to me today, feel free to contact me and happy to answer any questions you may have.
Hello again, everyone. My name is Caitlin Murphy, and I am the acting project coordinator. And so I did want to say, we didn't mention it during the introductions, but we do have our CDC project team here via live stream. So they can't introduce themselves, but we have Diane Mannheim attending, so we're excited to have them with us as well. So now we'll have a 5-minute break. I know some people did ask me about the Wi-Fi, and so I've got the login information. I'm going to make a slide for that and display it during the break so you guys can have that, okay? So if you could be back by 1:50, that would be perfect. Thank you.
Yeah, they do.
We really have to get these mics, these lapel mics, because this is hard to have to be in this. But I like being over there. So, sorry to our CDC friends. I just wasn't aware of it. Okay, so in this section of our kickoff meeting, we're going to talk about three things: the project structure, the project communications, and then the project timeline and work plan. This is very brief. It's not very detailed, but it's I need for you all to understand from a very high level, our approach. Starting with the project structure, I know you have this in your handout. This is very hard to see. I know you all can read this. This is not even eye chart material. But I gave you a sort of an outline so you can get a sense of how this project is managed. We have two primary focuses here. You can see in those two lower branches is the public health side and the health system side. And those two branches are extremely important because the overall integration of those two branches is the most important thing we're going to do in this project. So I'm going to go to the next slide and talk specifically about a little bit, just an overview about how we see, and you've already got an idea about the evaluation process which Dr. Thomas talked about. But our overall, the way we're looking at this, every quarter, we're going through this cycle of understanding what process changes we implemented, understanding from the evaluation standpoint from the metrics that were determined and the outcomes that we got, make sure that they get reviewed by our COPs. From that review, recommendations will go to the advisory board that they review. And then if process change needs to occur, there will be a consensus that will go out back to those strategies to implement that process change and through this cycle. So it's always a cycle of implementation, evaluation, review, and then process change, if needed. And it's an iterative process, and it's really important because I believe very strongly that this feedback loop is the way to do any population health management process. I mean, we'll get to that later. So the advisory board, just a little bit, currently the way we have it structured is there's a chair and a co-chair. Myself and Lori are the chair and co-chair. And then there's a secretary who's the project coordinator at this time. The members we have not identified yet, but we do know that what we want on that representative board, and again, this is an iterative process too, because sometimes it's hard to get C-level people to come to the board. But we need real decision makers at this level. And so we're looking at the board. I was trying to limit the board to be a few people, but it won't be a few people. It'll be probably a really big board, the way we're looking at it. But the most important thing, though, is not only the C-level people, but the key partners, and also we, as well as having patients in the room. Because that's really important, because C-level people can help us make the change, but the patients actually know what's going on. So that's the way the board is currently structured. That's our thinking. The meetings are going to be quarterly, 1 in person and 3 virtual meetings. The categories of the organization representation is everybody. Is the health departments, policymakers, administrators, payers, which are very important, academic researchers, hospital systems, community organizations, the state health department, and the community members that I mentioned. That is the composition that we see in terms of the category. Then and from that board, which is going to be fairly large, we're looking at these subcommittees. Because these are the subcommittees we think that will be in constant process evaluation. One is health information technology, sustainability, security, the quality of what we're doing, the dissemination of information and services, the partnerships, how is that really working, and then the social determinants. So the other aspect of what's shown in our structure is the COP, and the COP is very important in this process for us. The COP is a community of practice. The community of practice is the purpose of it is to support the dissemination of our best practices and our lessons learned, as well as to be sure that what we're looking at is a real innovation, and will the innovation be sustainable and go beyond our region? Because we're not just looking at Southern Maryland, we're looking at, can it go to all of Maryland? Can it go nationally? We want to be sure that we're doing something that will help the national push for doing this. And we want to be sure that our strategies are evolving, because the healthcare system itself is evolving, and we have to understand what are we going to do once the CDC money is gone. And Gloria and I are never going to get in a position again where we see 5 years later and we have to walk away from a project we know works. I'm not walking away from another project we know works. We're going to have this project, it's going to work, and we're going to sustain it if we don't do one other thing. The launch of the COP can be no later than March 30th, 2019. So we've got work to do to get this established. We need to reach consensus on a charter, establish our mission objectives. You know, the things that you do when you basically establish an organization. You want to be sure you have a champion and facilitator, a core team of folks who are going to come together. And if you've ever established a COP, and had to do that, you know these are the most important elements, especially confirming who the champion facilitators are. I mean, because that's really where the real work happens. You have to talk about what are your requirements for each member and how you're going to meet, and all those things that you can that you have to do. One of the other important things is to how you reach consensus, because the overall goal of the COP is to establish. How do you take people from being individual silos to being a collective? And that's what the community of practice is trying to take, especially health systems that love their silos, especially public health departments that love their silos. But whether you're talking about, it doesn't matter. And we've worked in my career, I've worked with a lot of different ones. And everybody loves their silo. How do you get everybody to come together and work together as a collective so that you have one thematic focus, or the theme-focused areas? How do you make sure that we're going to the same goal, we're following the same action plan, we have the same mission? And that's a piece of work, but I believe we can do that because I can feel it in the room. I want to feel it after the meeting too. This is sort of like the ecosystem of the community of practice. You can just look at this at your leisure. It just basically talks about, who are the sort of members of the community of practice. What do we do? What are our outcomes? Like in the green area, what are our outcomes for this particular community of practice? So that's what it tells you. That's it's a lot there to take a look at. Not that we're going to address everything, but we have to keep everything in mind. Whether it's the health equity, whether it's the social determinants, health literacy, whether we're using evidence-based practice, all of those things have to be kept in mind when you're pulling together a community of practice with a whole lot of different people, getting them to the same focus. So the structure and operation of the community of practice is, number one, is leadership. It'll go right down the drain without having a champion and a visionary at the top. It will not go anywhere else. So we know that's true. It has to have core governance. It has to have really strong logistics, because well, I don't need to explain that. And you need to have facilitators to help in discussions, because they can go off on tangents and talk about a lot of different things like I'm doing right now. And you don't want that. You want everybody to be on point because everybody's time is valuable. The general membership I sort of talked about before, but it's multi-sectorial and multidisciplinary, and it's going to be basically us and people we ask. And lastly, there are going to be 3 subcommittees for our COP. One of them is the public health. We talked about this a lot. Health systems and care coordination. One of the reasons we didn't want to make these separate COPs is because we need all of these things to work together. But then they need to work separately to understand their best practices or the inputs they're getting from what we're doing in the field, and they need to evaluate that. Sometimes they need to evaluate, you need to evaluate in your subcommittee and bring it back to the larger COP. So, and this slide is just a general, to point out what the general, how COPs actually, are composed and the elements of those, the general operations. And I'm not going to go through all of this, but I do want to, what I like the best about community of practices are, one, the collaborative problem solving. There's an exchange in learning, there's these facilitated discussions. But at the end of the day, if you can get together and do collaborative problem solving in an efficient way, in a collaborative way, you make much more progress than if you try to do it individually or in any kind of siloed way. So that's, and the leadership has to make sure everybody stays on purpose and point. So that is the structure overall of what we're intending to do with the project. This time we'll have Caitlin come up and talk to us about the project community.
All right, so hello again, everyone. As you know, my name is Caitlin Murphy. I'm the project coordinator for this project. And that means that I'm handling all of the logistics. So it's never a bad idea to CC me, because also I have an office right next to Dr. Carter, so I can bug him if you're not getting a response. But definitely CC or reach out to me directly about anything logistics related, anything task oriented. I can help you with those. I have a good finger on the pulse of everything that's going on in this project. And there are no stupid questions, so feel free to reach out to me for whatever. And then for those higher level things, you'll want to reach out to Brenda, our project director, with a CC to Dr. Carter and to myself. And so those would be anything, any big challenges or any major changes in your process, kind of those high level things that you want to make leadership aware of. And it's definitely good to let us know about those things sooner than later. As we've, a couple of us have mentioned, there are a lot of moving parts in this project. And you can see that by how many different people are in the room from so many different sectors. So so we'll need to know about any issues, because there will be some issues, I'm sure, and we'll be able to address those, quickly. So we are going to use a SharePoint site for sort of to collect all of our documents, have our events posted on there. And so to tell you a little bit about the organization of this site, this is the landing page. And so we have one main page which everyone will be on. And then we're going to have these smaller pages organized by each of those objectives that Dr. Carter went over in the beginning. And this is going to be really useful because many of you, if you think about the different objectives that your organizations are on, you may be working with different people for each of those objectives. So it'll give you a space where you can all communicate and share resources within that specific strategy that you're working on. And then we'll also have SharePoint sites for the COPs and for the advisory board. So we'll do most of our communications through there. Okay, and so I'm going to be sending out after this launch meeting. We're still it's mostly up and running, but we're making sure the glitches are all worked out. And so you'll be seeing something probably directly from the SharePoint site that'll give you an email to try to log in. If you're a county employee, there's a little bit different instructions, so I'll send those to you guys because you won't get an email. But for everyone else, you should get an email, and I'll send something out so that if you don't, you can just reach out to me and we'll troubleshoot and see what's going on there. Okay, and then the last thing from me, one of the things that you had distributed in your packet of handouts is a style guide from the CDC. It's from the Division of Diabetes Translation, and it's the language that they want us to use and the language that they would rather we don't use to refer to some of the diabetes-related programs. And so CDC, I know you're watching, I apologize, we're still learning the style guide. We may have misspoke a few times, but we're learning this as well. So whenever you're talking about anything project-related, please try your very hardest to follow this. And I'll send it electronically as well so that you can share it with anyone who will be working on this project. And so the other thing that will be useful is a like membership list of sorts so that you guys have each other's contact information. And so that's why I have that sign-in sheet in the back. I'm gonna use that to compile some of our information as well as what I have so far. And so you can look for that from me in the coming weeks. And so that way you'll have each other's contact information. All right, Brenda.
Hello again, and my name is Brenda Leith, and I'm the project director. My job is to help us get organized, to help us as a collective move forward through our timeline so that we can make sure that all the moving parts are happening in accordance with the way that they are supposed to, and that we end up where we need to be at the end of the project. So we've kind of organized the activities or tasks in buckets, if you will, and the buckets map to the quarters of the year. So if you think about the first quarter being where everything is happening with contract staffing, getting the stage set for working collaboratively, getting your work plans organized, getting the baseline assessments done, and getting the advisory committee established and their input on what it is that we are doing. So all of that is happening now because we are gearing up, again, as I say, for the next bucket. Which bucket 2 is focused on planning and development. So there are a number of tasks that are involved in the development. Among them include technical plans, training curricula, the technical assistance approach that will be used, the communications approach that will be used, how we will identify and share best practices, and most importantly, identifying the underserved populations and communities that we're going to be targeting in Southern Maryland. So all of this information has to come together, and it has to come together relatively quickly because it sets the stage for quarter 3, which is focused on strengthening infrastructure and building capacity. Remember in the previous slide you saw where there was a bullet focused on the technical assistance approach. Well, now you're implementing the approach and you're conducting the training and you're integrating technology and telehealth capabilities and you're integrating the bidirectional workflows and data sharing capacities. Because as Lorene talked when she was here, she spoke about the need to collect certain kind of data that we would be able to analyze and report on. So in quarter 4, you're implementing and you're conducting the process evaluation and reporting. So these are examples of the areas that will be of focus in that fourth quarter. So again, if you think about the project year being divided into 4 buckets. You have getting organized, you have planning and development, then you have building capacity, you're starting the implementation, and then you're implementing fully, and then you're also tracking and monitoring and reporting. So again, it's a lot of moving parts, and the best thing that we can do most immediately is to get organized, and everybody is on the same page in terms of what kinds of activities need to occur during what period. It's easy to get behind, very difficult to catch up. So in general, these are the project components. So you'll see they're color-coded, and this large purple is representing the implementation of bidirectional referrals and care coordination services. The yellow is patient engagement and health literacy. And the next largest component is evaluation. There are other activities that you can see on your handouts, and this isn't necessarily an accurate breakdown by percentage of the scope of these components, but it's intended to show you that much of the activity is focused on these big areas. The work plan, okay, this is just, again, so that you have a snapshot and see that, okay, we began with the award of the cooperative agreement mid-October of this year, and by the end of October 2019, we should have a report showing our progress. And, you know, I feel like there's a lot of positive energy in the room, and I know that we'll have lots to report on. My job is to help make it simpler by, you know, what I plan to do is to share templates with you so that the information is consistently provided to us in a consistent format, and you'll get used to that because you'll be reporting to us monthly, and I'm intending for it to be easy for you, not onerous, but easy for you to be able to systematically and standardize what information you give to us. Thank you.
All right, so we are really cooking through this agenda faster than anticipated, but we have another 10-minute break, so feel free to use the restroom, get some more food. I'll put the Wi-Fi information up again, and we'll come back at 2:23.
Keep going, keep going, keep going.
Keep going?
Keep going.
Okay.
This part of the presentation is about health department integration. Deborah Magruder had an emergency today, so she wasn't able to do this. So in a very succinct way, I'm just going to say a few words about it. And it is basically about how we're going to do population health management and how this has to be integrated into our public health stance. And I know I've been preaching this for a little bit, but I'm going to stay with it because I believe that the processes and networks that we put in place now has to remain with us. I was at the APHA this past week, and there was a lot of discussion about, well, how do you get these things sustained, and who is the person who actually, where is the leadership coming from? Because, you know, a lot of different health systems, they have strong leaders, but who's leading the population public health charge? It has to be us. We have to be the leaders of population health management. Now, this is Dr. Carter saying this is nobody else saying this. So that's why I said it in the meeting. Because we have to take charge of this process, because we are the protectors of health for large populations. So if they're not managed right, it's because we're not leading it. We have to lead it. The health systems have to understand where we stand in managing this process. Where do we stand? Well, first of all, we need to understand the population that we've got to manage. Then, secondly, we've got to do a health assessment on it, and that health assessment has to be true across the board, whether a hospital system in one place or another place in this big area for this big population. This health assessment needs to be consistent. Secondly, we got to stratify the risk. Thirdly, we have to stratify the risk. We got to know who's sick where and how to best get the resources to those folks. With the data that we can get, with the resources that we have at hand, we got a lot of strong resources in Maryland. And we're not going to let that go to waste. Because we're going to stratify that risk. We don't know where the sick folks are, and we're going to get them the help that they need right where they are. How do we do that? Well, we know there is a care continuum. You see that little, I can't point, but it goes from low risk to high risk. You know that's the care continuum. And so out of that continuum, we have to, there are 4 categories. And this, I will give credit to Well Center that they did this diagram, because I love this diagram. Because there are 4 categories that you can then get involved with on that, in that care coordination strategy. It's probably more, but these are good enough. One of them is health promotion and wellness. The other one is health risk management. The other one is care coordination advocacy. And the last one is the disease management. Now, that all has to come together. Those can't be separate silos. So when you go down into the chart, when you look at the person and you start to tailor those interventions and bringing together the organizational interventions, which means your cultural and environmental factors that are going to go into you creating that intervention, as well as bringing all the resources to bear that person, that has to be one well-coordinated thing. There can't be a whole bunch of people doing it in a bunch of ways. You understand what I mean? So if you got, and that's what when I first got into public health, that's what I'm looking at. I know you all look at the same thing. That cannot happen. What we have to have is a well-coordinated intervention for the person at the point of care. So if you're in rural, then we need to know how do we help somebody in rural America who has got to go a whole long way to get to the next. How do we help them at the point of care and beyond with the resources that we have? If you're in urban America, how do you do that? I mean, we know what the environment looks like. We already have everything that we need in the United States of America to be able to do this kind of thing. But you got to have a well-coordinated infrastructure to make this work. You have to have health information technology infrastructure. You have to have cooperative people who are working in silos who are coming together to solve those problems. Go back to the COP. You got to solve the problem. And then everybody's got to come to the table to do that. It can't be these people over here or those people over there. It has to be a coordinated effort. I think public health has to at least point the way and lead this. Because once you get those innovations done, and while you're getting those innovations done, you're spitting out these metrics that you should be able to evaluate that innovation that you're doing. And those metrics are going to have to get evaluated. These outcomes that pour out from those metrics are going to tell us a lot of things. And I like the categories they had at the bottom. They're going to tell us about either the person's physical health, we're going to understand about their disease outcome, we're going to understand something about their behavior, but the behavioral health outcomes, we're going to understand something about how they are productive and their quality of life. We're going to also understand about what impact that these interventions have on the financial system that we have in the United States. So you have to know what outcomes you're looking for. You can't look for one, you can't look for two. You got to look at the outcomes that you just did. Did you really affect the change that you said you're going to affect? If we did this by building a hospital, so if we build a hospital, will the hospital get us the outcomes we need? If it's no, then we don't build it. If it's yes, we build it. But if it's yes, we build it, how do we get to the outcomes? Then you know what else you need to get to the outcomes. So what we want to be able to do is to understand where we're going with the outcomes, and then it needs to be fed back. That's where the community of practice and the advisory board comes into play. It's got to be fed back. Somebody's got to look and say, did you do anything with the money that you just spent? We don't want to, I'll tell you the truth, we don't want to get into any situation where we're spending money, federal money, state money, or county money, where we can't say that we spent that money and we got the best bang for our buck, because we've had people who analyzed what we did and they gave us feedback quarterly on this. And we finally got to the conclusion that, you know what we first proposed, that wasn't really it. It's got to be something else. But we learned that because we were constantly looking at our outcome. That's important, and that's what this process is all about. That's what we're doing. And so when you talk about integrating into a health department, the integration really comes from the health department, taking the leadership and almost not demanding, but insisting very strongly that we do this. I hope that makes kind of sense, because that's where we're going. That's what we're going to do in this project. It's very important to know. So with that, I'm going to have Cézanne come up and talk about basically how you contract with us, how you get paid.
All right, good afternoon, everyone, again. Everyone can hear me fine, right? I can kind of talk loud. All right, so I wanted to cover with you just a high-level overview of the expectation with regards to our contracts process and reporting. So basically, so for vendors who've been notified that they need to register in our financial system, you'll notify us we will notify you once you have notify us once you've got your registration number, and also let us know if you're having problems with the registration process. Everyone should have received like a general email to say that we need people registered, because that's part of our process within the county. In order to be paid, you must be registered as a county-based vendor. I don't have contact information, but we can definitely get information from anyone who may not have received that information thus far. So once you've received your contractual documents, please notify us within 5 business days if you have any issues with any of the documentation that you've received. Please sign and return your contractual documents within 7 business days, along with a valid certificate of insurance. And it just needs to name Prince George's County of Maryland as the certificate holder and additional insured. Okay, there isn't a specific form, it just needs to have this information on there. Also, you'll be notified once your contract has been approved. So once you have an approved contract, you will receive notification from us. As far as where we are right now, we currently have an attorney from the Office of Law assigned to us, which is great news, so that can help expedite the contract process. And our contracts manager, Melita Giles, a lot of you may have heard her name. She will be meeting with you to kind of resolve questions and problems, and we're trying to work through contracts so that they're completed within the next 4 to 6 weeks. Okay. Next, we'll talk about our grant reporting period. So for this grant, as we all know, it's a 5-year grant, and this is a federal grant, so it's running on a federal financial fiscal year. And the reporting is one of the, I guess, happy or great points to just kind of give a touch point where we are overall fiscally with regards to the award. So the award of 2.4, kind of how we're doing in collaboration with all of our partners for our expenses. So we're going to be providing reporting through a continuous program monitoring and identifies successes and challenges and that grant recipients may face during the project period. So they anticipate that there will be some challenge, but the reporting with the specifications of anything that you encounter will be helpful. Okay, so the following are the required and optional reports that must be sent electronically through Grant Solutions. And that is the recipient evaluation and performance measurement plan that was mentioned earlier by Dr. Lorene Thomas, including the data management plan, and that is due 6 months into the award. The annual performance report, or the APR, is due 120 days before the end of the budget period, and it serves as annual continuation application. And the last slide is, this is the financial report. There's an annual report that's required on the federal financial reporting forms. It's also due 90 days after the end of the budget period, which is about December 31st. Also, the final performance and final financial report are also due 90 days after the end of the project. And all of our quarterly reports are going to come through on the payment management system. So typically every quarter we already have an account, so we're going to be notified through there that we need to submit a report to you all. And so these are the quarterly reports are due on January 30th, April 30th, July 30th, and October 30th. That's
Okay, so we, as you can see, have finished up a little earlier than projected, but this may be the most important part of the meeting. I know there are a lot of questions. So because we have people watching the live stream, what I'm going to do is have you introduce yourself loudly so I can hear you and tell me your question. I'm going to repeat it into the microphone so that they can hear, and then we'll have the appropriate person answer. Does that work? Okay, who has questions? Oh, one thing I need to tell you that I forgot to go over in my presentation is about a press release. So we will be doing a press release tomorrow. It is set to go out tomorrow. It's been approved and ready to go out. So after that release comes out, you are welcome to do whatever you guys need to do, release it internally or however you want to announce that, but we did list all of our partners on the press release. Yes, I can send it to you, yes. Questions? Yes, Laura.
I just have a question that's directly from the last presentation. The one question mark that came out in the presentation was about the certificate of insurance, maybe Georgia County now. Can there just be a little explanation on what it, are we just calling our insurance company and saying, please add a copy of it? That's just not something I've heard before.
Yeah, so they're not requiring us to have a specific form, but if you have your own certificate of insurance form, it just needs to specify a Georgia County on it. If you don't have one can be provided to you. You can just send emails and get it out to everyone, and so everyone can use one standard.
Okay, so to recap, the question was about the certificate of insurance. And the answer was we can provide for anyone who needs it. We can provide an insurance form. And so Giselle, if you get that to me, I'll be sure to get it out to everybody. Okay?
Sure, Kate. Good afternoon, James Bridges, Charles County Health Department. When you list your participating partners, you have your rural health departments joining you today, but they aren't listed. So could we have those health departments listed from Charles, St. Mary's, and Calvert, so it'll be a press release we can include in collaborative form?
Yes, so the question was about partners, and that and I have to apologize that the health departments were not listed on the partners page. That slide was made before we had made the rounds and talked to everyone, but I assure you all the health departments are included in the press release, and many more partners are included in the press release than are on that slide. Yes, Michael.
Hi, Michael Ryan with IPHI. Just a comment. I know we're gonna have to work through it, but you've got the advisory board and then a lot of subcommittees and the community practice and a lot of subgroups. So I think we want to be mindful of how we're using people's time to figure out how the advisory group and the community practice might integrate from time to time, so we can, because some of the conversations might be similar.
Sure. So I think the main idea is that they would be perhaps different people attending the community of practice and the advisory board. So for the advisory board, we were thinking more of those sort of high level, people who can make the institution-wide decisions that we would need and provide that strategic direction and oversight, whereas the communities of practice would be kind of more like the boots on the ground who are, in the weeds of what the project is looking like, and who then can provide as like a continuous feedback loop information to the advisory board to let them know how things are going if certain innovations aren't playing out the way we anticipated. But I certainly hear you, and we will definitely keep that in mind. We don't want to bog everyone down with unnecessary meetings because I know we're all very busy. I know there's more questions.
I have a question, Greg Taylor from the Environment, Health and Wellness Foundation. You mentioned that for contracting notification that the email has already gone out?
Yes.
And so if you haven't gotten an email, then what?
So I sent emails and phone calls to people who I knew were not in our vendor system. If you have previously done business with Prince George's County, you should already be in the system. If you are not, then you can reach out to me. I'll let Dr. Carter step in.
No, that's true. The one thing is that I want to be sure that you might, I can get back there. When I showed you the structure, be sure, and I know it's hard to see, but there are two major entities down at the bottom there. One of them is IPHI, Institute of Public Health Innovations, and the other one is TLC, Maryland. Those two entities are really playing a large role in terms of how we implement. So TLC, for instance, represents the health systems. And so they have in their budget the dollars for certain implementations. So you wouldn't have to contract with us, you would have to contract with TLC. In your case, Greg, I think you're in TLC's budget. As well, there are other entities that are in IPHI's budget. So every vendor doesn't contract with the health department. Only certain vendors contract with the health department. That's the most important thing to understand. And one of the reasons we did that is because, number one, if you can imagine trying to get a lot of contracts through the health department, how long that'll take. That's number one. And our partners like IPHI and TLC, they're nimble. They can move faster than the health department. We're bureaucratic, and we're changing our whole infrastructure is changing in the next couple of weeks. So you want to have so we wanted to be sure, we were cognizant of that. So we wanted to be sure that you could get, certain entities could get their contracts done quicker through those major entities. And so we're really concentrating on trying to get the major entity contracts done. That's IPHI, that's TLC, that's HQI, and those vendors. So that's why you wouldn't have gotten that. Okay. I hope that makes sense.
But I think it's important. We have never seen a budget. We have never seen the line items. So, or the scope of some of the particular areas. So I'm a little concerned about that because I was never asked for a budget. I was never told what the scope. So how are we going to get there?
You're going to get that through TLC, because TLC, what David and I have been working on making sure that we get that to you. But TLC and I are working very close. When you say David, to make sure that we solidify that. So we're taking care of you. It just takes it's a process, it's a process, and so I hope in this quarter we're trying to work through all of those processes.
Dr. Carter, what is the number of patients that you're trying to reach in these 5 years? Is there a number of patients, or?
Well, if you see from our outcomes, there's a population health approach. So we're looking at, like you see from our outcomes, if you looked at 50%, let me give you an example. We're looking at 50% of patients, this is really ambitious, decrease their blood pressure, get their blood pressure down to normal. In that region, 50%, So in that region, there's 1.2 million people. Other people who have hypertension is about 45%. So you're talking about 600,000 folks, and we're talking about getting 300,000 of them to get their blood pressure down. That's probably an overreach, but I mean, but we have to think in those numbers. So, but I'm not looking for medication therapy management for 300,000 people. So what we were going to do with medication therapy management, because it is one of the strategies, the most important thing to do is to demonstrate how effective it is, and then grow it, and how can we scale it out. And so first we got to be sure we understand the effectiveness of it in each one of these venues, whether it's the rural or, and you have done that type of work. We want through this process to show that and then scale it. Now, getting to scale, we want to work really closely with the CDC and our cooperative agreement to say, hey, this is a scalable event. We've shown great progress on this, and so I'll just leave it. I'll leave the dots. Do you understand what I'm saying?
Laura Wilson.
How long?
So there are different definitions of rural in
Mhm.
the state of Maryland
Mhm.
and different federal agencies. Do we know what kind of definition we're using? I don't know if the CDC has a specific definition of rural versus Maryland's definition of rural. Is that not important? Is it important? What are your thoughts on that?
I don't know how important it is. It'll be important in terms of when we're looking in the future to do grants that will apply to the federal definition of rural. In this project, not necessarily.
Right, because I mean, it's the state, well, the state marriage
Right.
but different federal numbers.
Right. Well, and I think that 12%, I mean, in Prince George's County, is, according to the federal government, is 2% rural. And I think St. Mary's County is 50% or 45%. I had that gum changed, Lord, I can't remember. If you're looking at, I mean, so yeah, it's there all, but I think we apply that specifically when we are looking to get more federal monies in to do some of the things we want to do. Yeah. Come on, somebody else has to ask me a question. Michael.
And I should say congratulations on getting the grant. These things are very competitive, so I know it's a short timeline. I'm really interested in sharing best practices and lessons learned across the national cohort. The CDC organizing conversations among the grantees, doing grantee meetings, anything like that?
Yes, and I think the first grantee meeting is in January. Mm-hmm. And then there's another one in March. I think that's, and we need to, and before we just go down to the CDC to talk, I think we as a collective need to talk about, what are we, I really want to get the collective input about how we go to approach those meetings. Because I know it's going to be a lot of understanding things, but we have, every region has unique needs and concerns, and sometimes, and because of the cooperative agreement, which I'm glad it is, because then we can also say, yeah, you have a little bit more wiggle room than you do when you're on a straight grant. So I'm glad you asked that question, Mike.
How many are they in the U.S.?
How many of these grants? I think it's 26. I don't know. So there were, and I can't give you all these details because I don't remember, but there's category A, there's category B, and then there are people who got category A and B. I think there were 26 total. I don't know how many people got, I think they said 14 got category A and B. I can't remember. It was, that's one of those data points I just don't remember. It was 14, yeah, I think it was 14.
So we're one of 14.
Yeah, I think that was it.
Yes.
I just have a question. So does the grant cover the people that might have chronic illnesses but not have access to care? So does the grant cover anything about that or not?
Well, what we're looking to do is to expand, for instance, your program. And we have to take, of course, you have to take into account a sustainable model, but it's going to have to, because public health led. It's going to be, how do we take care of the people who can't pay, can have Medicaid, Medicare, private? How do we do that whole spectrum? So we're not going to, this grant is not a grant where we say, we're not going to serve the underserved, or we're not going to serve people who can't pay. So that's why our models have to be inclusive of people who don't have insurance, who can't pay. Yeah.
So I just want to say the really cool thing about this project is that it was crafted kind of like in a genius way where every organization here today is doing what they are experts at. And so, you know, Laura, we would be taking your advice on what is the best way to define rural in this area. You know, we would be taking Dr. Bauer, you know, what is the best way to remove barriers? How do we reach these populations, and looking at health literacy? You know, we're taking each of your specific expertise and weaving it together in a way that has really never been done before here. And then trying to, you know, make, like Dr. Carter said, that like patient-centered health system. So I guess if you're sitting here feeling a little uneasy about the size of this project and a little unclear about what your piece is in it, just know that you are selected to be a part of it because of that expertise that you have. And so you'll just be asked to bring that to the table for what we're doing. Okay? Mm-hmm.
You mentioned earlier that there's a plan to release press release tomorrow.
Yes.
So is there, Dr. Carter, a strategic communication piece in place right now? Because once you push it out there, then what's the plan to back it up? You know, you don't want to push a press release out there and not have the ammunition to back it up.
Well, the good news is we have Delia Williams, Hawthorne Williams, in our health department, and who is geared up for this. She's ready. I've been in her office about 10 times from the time I've written the grant till the time we got it approved, because she knows that we've got it, and she's said the same thing to me that you just said. So I have all confidence in the world in her and her staff that we're going to be able to handle that. But you're saying, for you in particular, I don't know. I know for the health department, we're ready now.
That's pretty good. That's pretty good.
So yeah, no, we've anticipated that. The only last thing I'm going to say is, well, not last thing, but I'll answer whatever questions. But the other reason for this kickoff is really important, and what we discovered when we were talking to our evaluators, and we didn't discover this when we were writing. There are parts of this grant where that everybody shares. It's sort of, there's an economy of scale that can be done for almost every aspect of this grant. And so that means that this really isn't a silo grant. You really have to communicate in order for us to do these strategies. And I mean, give you a classic example. At the University of Maryland, the beautiful thing I experienced with Linda when we were doing the Health Enterprise Zone is that she had a bunch of students who did a whole bunch of things. I mean, and they did whether they were doing a trust campaign or whatever it was, they did extra things, but those extra things led to us being able to demonstrate aspects of care coordination that I hadn't anticipated. But it's because we were working so closely together in doing it, that's what helped. Though at the same time, when we were trying to get evaluation information and get it from door to door, I think we did a whole door-to-door campaign, then we landed down in 20743. And you can imagine doing a door-to-door campaign in 20743. How many people are you going to get to go into Capitol Heights and knock on everybody's door and say, I want you to answer these questions? That doesn't happen every day, but that happens in the Health Enterprise Zone. That's how we could get data. And it wasn't that I wrote it in the grant, but what I understood is that when you have people who have, we've got people who have various strengths and capacities. And when you bring them all together, then if you leverage those capacities, you can do a lot more than if the health department tried to say, well, we're going to go out and send some folks out in the community and do X, Y, and Z. Those students were motivated by different factors than my people would have been motivated. My people would have said, what in the world, I almost said a bad word, am I going out and doing this?
They still said that.
And the students were just eager to do it. So but that's the same thing I see whether I'm looking at the Maryland Rural Health Association, whether I'm looking at HQI, whether I'm looking at everybody in the room. Everybody in the room has these resources that we can leverage. So that's what I'm hoping that we can get to that point. Anybody else? Well, I'm gonna let you go. So the people can make it. It's not even 3 o'clock. So you can get back to work, get back to your office, toil away at whatever you were doing. Thank you guys for coming. I really appreciate it.